Hello and good morning, everyone. I'm Arjumand Siddiqi. I'm a professor at the Dalai Lama School of Public Health at the University of Toronto. And on behalf of Dr. Mabel Karabali, Dr. Vivek Goel, and Dr. Staney Brown, who are all helping to put this event on, I'd like to welcome you to what I hope will be a really fantastic series of 4 sessions that will take a look backwards and forwards in terms of what has happened in the field of population health and where we're going. I'd really like to warmly welcome you today to today's session, in which we will have a series of 3 speakers who will talk to us extensively about what the last several decades have looked like in terms of population health, as well as the sort of societal context in which population health has been unfolding. And I'm delighted to invite Dr. Vivek Goel to give you some introductory comments to the session. Professor Goel is special advisor to the president and a provost at the University of Toronto, as well as a professor at the Institute of Health Policy Management and Evaluation at the Dalai Lama School of Public Health. And he is also incoming vice chancellor and president at the University of Waterloo. Dr. Goel, pleased to welcome you.
Great. Thank you, Arjumand, for the introduction. And I'd like to just start by really thanking and congratulating you and Mabel for all the great work in organizing this symposium. And I'm really looking forward to the sessions over the next 4 weeks. This started with some conversations probably over a year ago that Dean Brown and I had about celebrating some key historical milestones that are happening in 2021. And I'm just going to mention a couple of them, and I'm sure you'll hear more about some of these thoughts from some of the speakers in a few minutes. But in 1971, the Federal Department of Health, Health Canada, created a long-range planning branch. So that's 50 years ago. And believe it or not, they were concerned about increasing healthcare costs, universal health insurance, or really more realistically, universal medical and hospital insurance had been introduced, and costs were increasing far beyond the pace at which people had anticipated. And so they'd had a commission of inquiry, and it led to the creation of this long-range planning branch to think about, in the longer term, how to optimize health in the most effective and efficient way possible. And led by a senior civil servant, Hubert Laframboise, a very important document was prepared, which came to be known as the Lalonde Report, after Marc Lalonde, who was the Minister of Health at the time that it was released in 1974. And many have characterized this as really one of the very first government documents that looked outside of medical care for how to improve health. So these weren't necessarily new concepts. And again, I'm sure you'll hear from other speakers about the work of people such as Thomas McEwen, the work of the hygiene movement going back well over 150 years, that had looked at roles of sanitation, nutrition, and so many other factors in leading to health. But in a government document produced for a federal government health department, this was a first. And the Lalonde Report introduced the concept of health fields, 4 fields: human biology, healthcare organization, environment, and lifestyle. And so it wasn't just about individual medical conditions. It wasn't just about the healthcare delivery, but really introduced these other 2 concepts of environment and lifestyle. Now, looking back at the document, I think all of us, the scholars that are now involved in this field, will find lots of things that may not have been quite right. It's been criticized for too much of a focus on individual lifestyle, blaming the victim. But we have to think of it in that era, what it meant. And we have to think in that era what else was happening in the world of public health. So the image behind me is the original University of Toronto School of Hygiene, which was established just about 100 years ago. It was one of the original Rockefeller Foundation funded schools of public health. In that same era, in the early 1970s, the School of Hygiene was closed by the University of Toronto based on the belief that the infectious diseases had been beaten and that chronic diseases would be addressed through better treatment. So the individual who wrote the report that led to its recommendation basically said it, we don't need to train more people in public health. We've got this beat. We certainly know that was not the case. So that was the predominant view at the time, right? That the medical care system was going to take care of everything. And so the fact that a federal department was putting out this kind of report at the same time that one of the major schools of public health in the country was being closed, I think is an interesting thing to think about. So the Lalonde report went on to be the basis for many significant contributions in Canada as well as globally. And some would say it helped drive the creation of the field of health promotion. Another key milestone, and I saw your poll question referred to this, was a highly influential article and then book by economists Robert Evans and Greg Stoddart. And this was published 30 years ago in 1991. And it was through the Canadian Institute for Advanced Research. At the time it was called CIAR, and now it's referred to as CFAR, Population Health Program. And that program was established through the incredible foresight of the founder of CIR, Fraser Mustard, who in an institute that was focused very much on the hard sciences, astronomy and genetics, human biology, also chose to invest in a program in population health. And that led to the publication of the 1994 landmark book, Why Are Some People Healthy and Others Not? I'm looking forward to seeing how many of the respondents said they'd heard of that title. And several speakers that are involved in today's program, including John Frank, a very significant mentor for me, were part of the population health program. And Michèle Lamont was part and co-leader of the Successful Societies program of CFAR, which has continued in this tradition. And the model really expanded on the health fields framework and other frameworks that were in place, and with a particular focus on the role of social environment in determining health outcomes. And they particularly put a focus on inequalities and health and social determinants. It was very influential in the development of many health policies and research in Canada and beyond. In Ontario, we had a Premier's Council on Health and Wellbeing, which was very much based on the concepts and thinking from the population health group. We had a network of centers of excellence in population health that both John and I were involved with called HealNet that had a population health theme. And then the Canadian Institutes of Health Research were created outside of the old Medical Research Council and moved its areas of research beyond clinical medicine and basic medical sciences into health services and policy research, as well as into population and public health. And John was the first director for the Institute of Population and Public Health, and Morris Baer, another member of the group, was the first director of the Institute of Health Services and Policy Research. And we also had the creation of the Canadian Population Health Initiative based in the Canadian Institute for Health Information to improve the quality of data to drive decision-making around population health. So over the course of the first 20 or so years following the publication of that paper and book, we had a significant impact on both health research as well as health policy in Canada, as well as around the world. So there are many critiques, again, of this model, as well as the Lalonde model. But I think what we really need to think about is the fact that it created this perspective, it created this kind of scientific dialogue. So I'd like to turn quickly to where we're at today and what I'm hoping personally to get out of this symposium. So we've had decades of work on population health, on inequities in health, on what kinds of policy programs that we need that are really outside of the healthcare system. Yet we continue to have challenges in getting focus on this. And just consider the response to COVID-19, and I'm sure through the symposium we'll talk about this a lot. If we look at the dominant narrative, it continues to be one on the needs of the healthcare system and the response of the healthcare system. Early on, we were focused on manufacturing respirators and finding therapeutics and PPE, and that vaccines were going to save us. And I absolutely want to say vaccines are our route out of this. But we haven't really had, until far along in the pandemic, a focus on the broader population health issues, and the role of public health in dealing with the pandemic. And we didn't have the investment in many jurisdictions, certainly here in Canada, in the supports that are required to address the pandemic on the front lines. It was, while many of us, I think, were starting to talk about right away, certainly Arjumand was in the news regularly talking about the inequities that the pandemic was introducing, it didn't really enter the popular discourse for many months. And we know now what the social determinants of health frameworks would have predicted, which communities are most affected by the pandemic and which communities are also most affected by the public health measures taken in response to the pandemic. But it's still not a dominant discourse in the media. And even today, we continue to have very significant debates about the need, for example, of social support for essential workers who come from largely from low income communities for things like sick days supports. So even with a continued focus on the medical response, on vaccines, simple social interventions that would go a long way seem to be ignored. So it's not surprising that population health writ large is not as much on the dominant discourse as the healthcare system. When I was involved in leading Public Health Ontario, and I talked with deputy ministers and ministers of health about why this is the case, it was a very simple response. It's not on the public agenda. When politicians are knocking on doors at election time, what they get asked about is, why is my aunt waiting for her hip surgery? They don't get asked about social supports, social determinants of health. And so I really think one of the things that we need to be talking about is, how do we change that discourse? How do we take all this great knowledge that we've got and bring it out into that political agenda? The other thing that I would really emphasize we need to work on, and it's great to see the sessions that we'll have through the symposium, is moving to intervention research and evaluating the interventions that can be done. And we need to think about this outside of the language of healthcare, because again, the conversations I would have when I would go in trying to promote population health in government and other places, say, where's your evidence? And people would be locked into a very clinical paradigm of evidence. Where's your randomized controlled trial evidence? Policy interventions, social interventions will not always be evaluated in that way. They're complex. We need very different types of designs. We need to draw on methods from other disciplines in making the case. And then finally, we need to think about, how do we get the data that is required to support this? We simply do not have the health information systems in most countries of the world at a population level that produce data in the way we do for the economy. And until we get to that stage, I know we've talked about this for many decades, we're going to have challenges in doing the kinds of complex evaluations I just talked about. So I'll close with that and just say that I'm looking very forward to this symposium and to the discussions that we're going to have. And again, thank Arjumand and Mabel, as well as all the speakers, all the support that have helped make this happen. And turn it back to Arjumand.
Thank you so much, Vivek. That's a wonderful introduction to the field and to Canada's role in it. So before we start with the rest of the speakers, I just wanted to take care of a couple of housekeeping things. One, just tell you roughly about the schedule. So we'll hear from the three speakers, Doctors Kawachi, Frank, and Lamont, in that order. And then we'll take just a quick 2-minute break just to stand up and stretch, after which we will have a discussion between the three panelists that I'll moderate, and then we'll open up to the Q&A. And so if you could put your questions in the Q&A, we will try to answer as many of them as we can in the time that we have. The one other thing to mention is that the chat is open. And so you're more than welcome to use the chat to have discussions on the side as the presentations are going. In fact, we're hoping that part of what happens from this symposium is that people get a chance to connect with each other in real time around these ideas. So before I introduce our first speaker, I would like to start by acknowledging the land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, this meeting place is still the home to many Indigenous people across Turtle Island, and we are grateful to have the opportunity to work on this land. I'd like now to introduce Dr. Ichiro Kawachi. It's a great pleasure to introduce him. Dr. Kawachi is the John L. Loeb and Francis Lehman Loeb Professor of Social Epidemiology at the Harvard T.H. Chan School of Public Health, and all of you have a link to his bio. He has the unfortunate burden of having been my doctoral supervisor and has been a longtime mentor, and is just an absolute giant in our field, and has been one of the foremost social epidemiologists really of all time. And so it's just such an honor and such a pleasure to have you here, Ichiro, and I will hand you the mic.
Great. Thank you very much, Arjumand, for the kind introduction, and it's a pleasure to be here. So I was charged by Arjumand to address a few remarks about mainly about the past and present of the field of population health. And I'm going to do so through the lens of social epidemiology, which is actually my expertise, and as a smaller subfield within the broader domain of population health. And I'm going to, in the time available to me, speak about how the field of social epidemiology during the last 3 decades, 2-3 decades since the publication of Why Some People Are Healthy and Others Not, how we have been both looking inward and outward at different influences on population health. I'll address a few remarks about methodological innovations that we have made. I'll make reference to some critical ongoing debates in the field, and then lastly, round off with some emerging themes. So with regard to looking inward and outward, what I mean by this is the very, very popular kind of heuristic, which is often brought up in discussions of population health. And this is the idea that health is, the influences on population health are kind of nested within each other, rather like a Russian matryoshka doll. There's sort of a nesting influences on health that we need to simultaneously consider. So on the left-hand side, I've cribbed a figure from an article that was published about the determinants of childhood obesity. And you can see that rather like this nesting doll figure, we begin at the lowest level, at the cellular level, namely the genetic and microbiome as determinants of obesity. Then we have the individual herself, the child, where we may consider aspects like their self-regulation. And then the child is herself nested within the family. It says clan here, and of course their household processes, which influence dietary and physical activity habits. And of course, the family is nested within the community within the country, and then it goes all the way up to culture. That's the kind of common heuristic. There are many, many versions of this same diagram which describe the way that we have been considering determinants of population health. Now, a long time ago, when I started as a assistant professor at Harvard, my colleague, the Harvard biomathematician and ecologist Dick Levins, pointed out to me a very interesting observation, which is that the prestige of an academic field is inversely proportional to the size of the object being studied. I thought that really struck me. And for instance, if one studies molecular genetics and subcellular processes, you can attract lots of funding. There's an enormous amount of prestige attached to it, and the possibility to win Nobel Prizes. But if we think about a field like social epidemiology, which is primarily focused on society, large objects like society and how they influence public health, well, then you better be prepared for a lot of misery in trying to attract funding and prestige and so forth. I felt quite depressed after Dick Levins told me this. But looking back, I think the field in the last 30 years has made considerable progress in engaging with the smaller objects as well. That's one trend that population health and social epidemiology has followed. And so, for example, there have been big breakthroughs in understanding stress mechanisms. How does social conditions, such as socioeconomic disadvantage, get under the skin, so to speak, to influence biologic processes and ultimately health? And so we've had breakthroughs in concepts like allostatic load, introduced by Bruce McEwen, as well as concepts of cellular aging, introduced by people like Elizabeth Blackburn, who won the Nobel Prize for her study of telomeres. And so we haven't just sat back and looked at only bigger objects. We've tried to drill inwards as well. In addition to that, we've been looking inwards more recently at concepts like epigenetic changes, the methionine modification and so forth. And this has been applied quite successfully, increasingly successfully, to fields like life course epidemiology, the DOHAD program, the Developmental Origins of Health and Disease, which considers whether some of the changes that we observe over the life course can be detected in the signature of epigenetic changes. There's been developments in understanding or linking brain structure to social conditions. And there's a whole emerging field of population neuroscience. And then in a field that I have been increasingly interested in, we've been trying to integrate observations at the population level to more sort of within individual psychological traits. And so in the field of behavior economics, I think the concept of scarcity has some applications to what we try to study in social epidemiology. What is scarcity? Scarcity is a sort of term popularized by two behavior economists, Sindil Milnathan and Elder Shafir. They wrote a book about this, where it's essentially a psychology of poverty, if you will. They argue that the condition of scarcity is associated with an uncertain environmental context, and that context imposes a bandwidth tax. This is how they talk about it, a bandwidth tax on our ability to plan for the future. And specifically, people under these circumstances develop a kind of tunnel vision, which can be detected in economic experiments where individuals faced with uncertain circumstances can become much more present focused. And this kind of present focus or inability to plan for the future has important implications, I think, for the kind of patterns we observe in larger society of scarcity and various health outcomes. Now, the important point that the authors are pains to make is that people are not born short-sighted. This is not a biological or inherited predisposition. Their argument is that anybody who is placed in that situation are apt to develop the same set of behavioral responses. So, for example, most of you would probably be aware of the famous marshmallow experiments and variations of it, originally devised by Lawrence Michèle, in which a child can be brought into a room and given a choice between a smaller reward now versus waiting for a larger reward later, and that's one measure of patience, if you will, delay discounting, we call it in economics. Now, that this experiment, I know that Michèle's experiment has been criticized on a number of grounds, but let's just say that it's been repeated tens of thousands of times in various versions in the field of behavioral economics. And I think it's a fairly robust phenomenon. There are population variations that we can detect in the marshmallow experiment. But I think an interesting tweak on this experiment was reported some years ago, in which they repeated the marshmallow test, but they introduced a slight tweak, which was to make the experimenter unreliable. They randomized the children between interacting with a reliable experimenter versus the unreliable experimenter. That is when I say unreliable experimenter, I mean the experimental confederate who is conducting the experiments would promise something to the child and then later appear to forget about it, so that the child quickly develops a sense that this this adult in the room is untrustworthy. And so they deliberately introduced a condition of environmental uncertainty and randomized the children to these two conditions. And lo and behold, when you do this, children who are randomized to work with an unreliable experimenter were much more quick to give up on waiting for the larger reward. They were significantly less patient. They caved in within an average of 3 minutes compared to children working with a reliable experimenter who could wait for up to 12 minutes on average before they caved in and went for the smaller reward now. And so I think that increasingly we view scarcity as an important context in which we must understand concepts like self-control. Environmental uncertainty imposes a tax on people's ability to plan for the future, and planning for the future is an important component of many kinds of health behaviors. Now, poverty is itself a condition of uncertainty, because if you think about what it means to live in poverty, there's all kinds of uncertainty associated with job insecurity, financial insecurity, housing, food, health insurance, and so forth. And that we may say that scarcity, this kind of scarcity tax, is a part of the explanation of why there is a robust correlation between low SES and a variety of health behaviors. Now, I want to be very short to emphasize the point that, of course, there are many other structural reasons for the correlation between SES and health behaviors. I mean, not the least of which is the behavior, the unscrupulous behavior of the producers of unhealthy products, cigarettes, alcohol, fast food, and so forth. So we have major structural barriers to achieving good health, but this is one way in which I think an integration of the micro scale of understanding scarcity has been linked in with the more macro observation of robust correlations between SES and a variety of health behaviors. This is from a study looking at adolescent health behaviors, showing gradients in smoking, physical inactivity, weekly food consumption, alcohol abuse, and so forth. These are all behaviors that at an individual level is partly related to the ability to delay gratification. All right, so that's one, and this is sort of a quick guide to how I think the field has been looking inward. Looking outward, this is the bread and butter of social epidemiology, and I think the last 3 decades have seen remarkable progress in understanding the influence of various social contexts, um, the influence of neighborhood contexts on health outcomes like physical activity, diet, obesity, as well as contexts like workplaces. This has been accompanied by an explosion in multi-level analytic methods. We have extended outwards to the macroeconomy, to studies that have tried to understand the connection between growing income inequality as well as recessions on population health. There's been a massive increase in our understanding of structural racism, not just racism on a person-to-person scale, but at the institutional level, and how policies such as mass incarcerations, police brutality, and so forth have affected the health of people. We are beginning to enter the realm of cross-national comparative studies because of the increase in studies with harmonized data collection and designs across many developed as well as middle income countries of the world. The in-depth network is an example, but there have been others that are modeled on the US Health and Retirement Survey that have spawned a variety of harmonized studies across the world that has made increasingly possible cross-national comparative studies. And I think careful cross-national comparisons will help us to understand the population determinants of health even better. So accompanying this kind of looking inward and outward, there have been some methodological innovations in the field. Dr. Goel mentioned randomized controlled trials. Well, of course, in the field of population health, these kinds of trials are seldom practicable. There are only a few examples that immediately come to mind. In the US, we have had the Moving to Opportunity trial, which was a study of residential mobility to try to understand the influence of neighborhood context on various outcomes. And of course, we have studies like the high scope Perry preschool program, which is still cited today as a study of early preschool education on later life outcomes. That was done in the 1960s. And I think apart from these examples, it's hard to imagine that randomized trials being either affordable or ethically practicable. And that limitation in our field, I mean, when you're studying society, it's difficult to randomize in the same way that one would be able to in a clinical setting where you can develop a pill and a sort of nice placebo to go with it. So we have had to leverage all kinds of natural experiments in order to get to the causal question. For example, leveraging variations in the introduction of compulsory schooling laws across countries at different times, across different states of the United States of America, in order to understand whether and how education and schooling can affect health outcomes. And we've done the same kind of, taken the same kind of approach with social policies, using them as natural experiments to try to understand the influence of policies like housing, social welfare, income support, and so forth. And even, as I'm going to show you in a moment, using natural disasters as an occasion to understand social determinants. And together with these kind of innovations, we've had the increasing use of econometric methods borrowed from economics and other social sciences methods such as fixed effects analysis, instrumental variables, regression discontinuity, difference and difference, and so forth. The details here need not detain us, but they are the ways in which we've tried to overcome some of the limitations of the difficulty of conducting randomized experiments. Now, I'm going to give one example out of my own research on how natural disasters can be leveraged to answer questions about social determinants. And the study I'm have been working on for the last 10 years is from the 2011 Great East Japan earthquake and tsunami. As you, many of you may recall, we're coming up to the 10th anniversary of that disaster. And interestingly, prior to 2011, I was not a disaster researcher. I didn't consider myself to be a disaster researcher, but I inadvertently became one because 7 months before this disaster happened, some colleagues of mine had established a nationwide cohort study in Japan to examine the social determinants of functional disability. They wanted to know, why do some people live their whole life free of disability and others develop disability early? And so they established a large cohort study of about 120,000 people with field sites scattered all over Japan, all the way from the northern island of Hokkaido to the southern islands of Okinawa. And as you can see highlighted in yellow here, one of the field sites of this study was the city of Iwanuma in Miyagi Prefecture, which by pure accident was about 80 kilometers to the west of the epicenter of the earthquake. And so this aerial photograph actually shows our field site being attacked by the waves of tsunami on the day of the disaster. And so this aerial map shows the Pacific Ocean on the right-hand side, and then in the blue dots represent where did the participants in the cohort study established 7 months before the disaster, where do they live in the city boundary? And I think you can just see the light red line, which I've drawn in this map, which is the extent of tsunami penetration. And what this is actually a natural experiment, because you can see from this diagram that some people were directly in line of the tsunami, and their houses were severely damaged or destroyed, and other people who were to the west of that red line were largely spared the tsunami destruction. They had some shaking from the earthquake, but the houses were not flooded. And so we can use that kind of natural experiment to understand other topics in social epidemiology. And so one of the things that quickly came up when we followed up the sample was that there was a remarkable increase in the incidence of overweight and obesity amongst people who were displaced as a result of the disaster. So this is where having pre-disaster data makes a huge difference. We divided the population into people who were displaced and those who were not displaced, and this is showing the percent obesity. Actually, in the United States, we would call this overweight, but BMI of 25 or greater in Japan is classified as obese. And so in the population in our sample who are not displaced, you see there's no change in their prevalence of obesity before or after the disaster. However, amongst the people whose homes were damaged and they had to be relocated, there was a remarkable increase in their risk of obesity. Why? And so we've looked at different reasons why this happened. Obviously, one of the things that happens when people's homes were damaged, as on the left-hand side, is that they would be evacuated to essentially these temporary homes. They're sort of essentially container homes that were provided by the municipality for people who suffered this kind of housing damage. And what this is, if we sort of take a step back and consider what has happened here, is a change in their housing, but also their neighborhood context. It is actually a natural experiment on neighborhood change. And so we considered this natural experiment as an instance of how neighborhood food environment, change in neighborhood food environment could account for the increase in obesity, could at least partly account for it. And so we are able to go through historical records and business records to map the location of every fast food outlet, convenience store, and bar in the city of Iwanuma before the disaster and after the disaster. And then we could consider the residential address change for every person in the study to be able to map for each person, do they move closer or far further away from neighborhood amenities like bars and fast food stores. And so what this diagram is showing is that the hatched area, the area in the red hatching is where the tsunami inundation was most severe. And if you live there, you're likely to have to move house. And after the disaster, most people who lost their homes moved to this location in the blue cross, which is where the temporary housing was built by the city. And I think you can see from just by looking at this picture that the impression that people whose homes were destroyed lived further away from bars and fast food outlets before the disaster, but by accident, when the temporary housing was built, that they ended up moving closer, much closer to fast food outlets and bars. So this is the kind of a natural experiment that would not be possible under normal circumstances. So here's an example of the change in the proximity to fast food outlets amongst displaced and people and non-displaced people. Among people who weren't displaced, there was a sort of a slight increase over the 3-year follow-up period in the number of people living within 500 meters of the nearest fast food outlet. But the big change is amongst people who are displaced. You can see in the pre-disaster scenario, they were much less likely to have a fast food outlet within the nearest 500-meter area of their residence. But that proportion increased spectacularly after the disaster. And we can put this into a fixed effects analysis, showing that as people moved closer to fast food outlets and bars, that this was correlated. It was correlated with about a 50% increase in their risk of transitioning from being normal weight to obesity. So that's just an example of how social epidemiology has tried to leverage natural experiments. Now, I'm sort of running out of time, but I'll just mention some critical debates. Social epidemiology is a field that is constantly being reflective and debating whether what we're doing is in fact a move in the right direction. And so there have been critical debates about the rise in counterfactual reasoning, the use of potential outcomes framework, and whether that is appropriate for the kind of questions we ask. You know, whether counterfactual reasoning forces everything into every question into a framework where the answers end up being inherently conservative. And if we have time for discussion later, I'm happy to talk about this at greater length. There's been debates about the limits of randomized controlled trials. What can we learn from them, and when are they appropriate? This is a debate that was spawned by Angus Deaton and Nancy Cartwright. And of course, we continue to have contested debates about contested concepts, including race, gender, social class, social capital, and so forth. Lastly, with emerging themes, we've been engaged increasingly in concepts like intersectionality. I always think of the disparities in the ability to telecommute during the pandemic. For example, occupationally, university professors were much more able to adapt to telecommuting compared to frontline workers. So that's a huge occupational disparity there. However, we need to consider the intersection of occupational class with other statuses such as gender, because we know that even amongst university professors, there's a huge gender difference in how people have coped with telecommuting. Namely, if you a family with young children and you have to homeschool them and so forth, much of that burden we know has fallen among women academics, and so the intersection of class and gender has to be considered when understanding the effects of pandemic policies on people's lives. I know that Arjumand is going to speak about this at some point, but we have been focused on population health effects of what I call neoliberalism. The rise of neoliberalism in the last 40, 50 years has coincided, we say, with other population level phenomena, such as the increase in the deaths of despair. And then lastly, COVID-19 itself I predict, is going to keep this field occupied for the next decade, because when we consider the effects of COVID-19, it touches upon every aspect of social epidemiology. COVID-19 is relevant for social class disparities, gender, race, neighborhood effects, neighborhood segregation, occupation, immigration status, on social capital, social support, income inequality. So if you take a list of the chapter headings of our textbook on social epidemiology, COVID has immediate relevance to every one of these topics, and it is a subject which will keep us occupied, and we need to make urgent contributions to try to understand and mitigate these kinds of disparities. So I apologize, that was a bit rushed, but that's how I see the looking back and the future of our field. Thank you.
Ichiro, thank you so much. That was fantastic and exactly the kind of sort of comprehensive view that we were hoping to get from you. For the audience, you'll see a poll that's been put up. We'd like to invite you to answer this question in relation to Ichiro's presentation. What social determinants or societal determinants have been most influential for your understanding of population health? And we'll try to put those answers up a little bit later. I'd like to, just in the interest of time, introduce Dr. John Frank. John, if you're ready, you are great. So again, there's a link for John's extensive bio, but he is the former director of the Scottish Collaboration for Public Health Research and Policy in Edinburgh, Scotland. He also holds a chair in public health research and policy at the University of Edinburgh. And more sort of to the point, John is really one of the Canadian pioneers in population health, and it's just such a pleasure and an honor to have him for this session in particular. So John, I'll hand it over to you.
Thank you, Arjumand. Can you hear me?
I can, yes.
Good, okay. Well, it's a great pleasure to be here. When Arjumand asked me if I would kind of revisit some of the key ideas that the CIAR Population Health Program were chewing on in their first decade or so, I jumped at the chance. It gave me a kind of the first opportunity, actually, in my life to reflect on these ideas and how formative they've been for me and for others, I think. So with no further ado, and some of you who've been around this field for a long time will recognize a few slides that I dug out of my archives, which are actually Fraser Mustard slides and a few of Clyde Hertzman's, God rest their souls. So let's move ahead. So of course, I'm going to refer to some, but a very small fraction of the key ideas in the two books that the program wrote. The first one, a labor of 7 years. I remember Fraser was always pushing the group to get at it and finish the book, but it still took us till 94, even though much of it was written by 91. And then the second book edited by Jody and Clyde and Morris and Bob. And if I had to do you a quick, 2-line summary of how most of the field, that is population and public health, now views these books and the ideas in them, I think I would say that the strengths would be inequalities, health services and policy, and biology. There's a lot of biology. But in retrospect, and of course, the retrospectoscope is unfair, isn't it? They're very weak, or often have nothing to say on gender, race, nothing to say on neocolonialism, the role of multinational corporations such as Ichiro said, the purveyors of hazardous or marketable goods, big tobacco, big food, big alcohol, big gambling, big you name it. And of course, the environment. So with that sort of background comment, I'm going to try to look now at some of the key ideas through the retrospectoscope and describe them, and then sort of ask you what you think of them now, and tell you, if I can, if I'm able, what I think of them now. Now, the first idea, I think, has a real datedness about it. As Ichiro rightly pointed out, we were heavily influenced by the writings of Thomas McEwen, a Canadian working in the UK, and publishing largely in the 1970s. And of course, the ideas of the Lalonde Report. And a key element of those ideas is that medical care is inherently limited in what it can achieve in the determination of the health of a whole population. And so we tended to state it rather boldly as not a major determinant of population health status. And just to show you how far this penetrated our thinking, when I started at CIHR's Institute of Population and Public Health in the year 2000, my colleague Erica de Ruggiero and I created this diagram, which shows the conceptual framework we wanted to put forward as the basis for the main work of IPPH. And it shows the nested spatial entities that Ichiro already pointed out in the blue diagram, through which these forces, political, social, and so forth, act on the exposures in our life as we go through the life course. Ichiro also pointed that perspective out. We are affected by our biological endowment, both genetic and epigenetic, but we have all these exposures that are arrayed across these nested spatial entities, and they interact and they create together health outcomes in the upper right-hand corner. And look where we put most healthcare. And so my question to you is, and then I'll tell you what I think myself, is healthcare really that trivial, a determinant of health? Here's what I think. I've changed my views. In the current era of universal health coverage, probably what matters is access to and cost of care for patients, which we weren't thinking too much about under the universal Medicare system of Canada that was well established by the time the population health program was regularly meeting in the late 80s. But I have now had more experience with other countries, and I think that globally, access to and the way care is paid for is an important determinant of health, and certainly of quality of life, particularly as we age. Part of this is due to the greater capacity of modern medical care to ease some of the ailments and disabilities of aging, particularly through procedures such as joint replacement and cataract extraction, various kinds of assistance for the disabilities that afflict us as we age. I had a recent experience that brought this home to me, which was that in 2019, I was asked to appear as an expert witness for the federal government, which were co-defendants against the Canby surgeries based in BC, who were alleging that that the Canada Health Act and the particular act in BC, which supports it, was not in line with the Canadian Constitution, and that it actually prevented Canadians from purchasing care that they could afford, a more rapid care, particularly for those elective surgical procedures that I've already mentioned. And in that process, I could pretty quickly saw how serious the threats are to universal healthcare in Canada. But I was pleased to see how committed the federal government is. So many years since the Canada Health Act was passed in 1985, through the efforts of Honorable Nick Bégin and others. So I just want to ask you in closing this theme, the limits to medical care, is there scientific evidence? Have you seen scientific evidence that Canadian Medicare has reduced health inequalities over time? Well, I know of one study, and I'll throw it up here. It's not totally convincing. It's James Wilkins, Russ Wilkins, of course, Alan Detsky, and others, paper in JECH in 2007, where they divided the cases of death in Canada over a 25-year period from 1971 to 1996, so 25 years after Medicare, including ambulatory as well as hospital care, was pretty thoroughly established in all the provinces. And they found that if they, on the y-axis, we have the difference, I think it's by household income, between the top and bottom quintile of the population in age-standardized years of life lost. So it's a direct measure of premature mortality gap between the top and bottom quintiles of income distribution. And what you see is this steady and major decline for those deaths due to causes amenable to medical care. Something not seen in the other categories of death, although in retrospect, the reason you couldn't see it for public health is that during that 25-year period, very few robust policies were enacted, such as tough tobacco legislation that could have used scientific knowledge in a public health intervention to improve health. And then you'll see some effect on male heart disease, less on female. Well, males started at a much higher base. But this evidence is suggestive. The reason it's not convincing is the paper doesn't do any comparison to any counterfactual or other nation state. So, for example, they could have tried to do a comparison with the USA. It wouldn't be easy, as Ichiro and many of you know so well. But I think most people would agree, I'll be interested to hear in the question and answer, that nobody thinks the USA's health inequalities measured in this or any other way have come down in the same way. So if you believe that study, let's hear about it in the Q&A. If you think it's rubbish, let's hear about it in the Q&A. The second class of determinants that the group was fascinated by were the macro socioeconomic and cultural factors that operate at the level of whole societies. Or as I always say when I teach this, you might be the best behaved person in the world in terms of your health habits. But if you are born onto a ship of life, that is a society that is going to hell in a handbasket, you're going to be affected. And we often use the case of the USSR since 1991 crash to evidence that proposition. And we use the example of Japan to show how the opposite is true. A society whose ship was sailing strong for decades and decades has had ever longer longevities. But today I'm not going to use that example. I'm going to use an example that Ichiro knows intimately. I think this is your paper with Bruce Kennedy's, Ichiro. And it's, if I'm wrong, apologize. For some reason, the actual attribution has been taken off this slide. But this is very old slides, and I hope it depicts the graph that was originally published. And it just shows for a number of OECD nations a fairly strong linear correlation between the percent of income received post-tax and benefits by the least well-off 70% of families on the x-axis, a clear measure of income inequality, and overall life expectancy at the societal level. And what I remember, and I don't know if you were there, Ichiro, but perhaps others in this Zoom meeting were there, and they can tell me their version later. Can you remember that the meeting at which this was presented also invited the CIR populational program meeting, Ken Judge from the UK, who basically accused the authors of this paper of cherry picking and not including data from the countries that didn't support the hypothesis, which we now, of course, call the spirit level hypothesis. So I'd be interested in others members of that. So why do we call that? Because, of course, Richard Wilkinson and Kate Pickett, who I was lucky enough to teach as a postdoc at the University of California, Berkeley School of Public Health 20-some years ago, and a brilliant person, published the spirit level book, Why Inequality is Better for Everyone, a decade ago. And just a word for those of you who've always found the book irritating because they wrote it for lay people and felt they needed to simplify it greatly. And so they took all the axes off all the graphs, and there are dozens of graphs in it. So it's a bit irritating for a researcher. But if you read their causal review in the International Journal of Epidemiology about 2015, I think you'd be much better convinced that their hypothesis has tremendous support. And my take on it is that is broadly true in the public and population health community now, although there are many exceptions, as I'll show you in a minute. During the CAMBI trial, after I testified, I had to wait until September, which is, I think, 10 months later, September of 2020, to see the Justice Steve's final verdict. And he more or less concluded that the spirit level effect was credible, one credible reason not to find in favor of the plaintiffs, the CAMBI Surgeries firm that wanted to strike down the BC Medical Protection Act. And have the right to freely not only charge what the market would bear for their expedited surgical services that are an insurable benefit. They're not cosmetic procedures. You can read this quote for yourself. You'll have these slides, but I felt gratified that I'd managed to convince Justice Steves of this in my testimony, and as the only social epidemiologist that was called to testify. And I felt grateful that I wasn't taken to pieces by the lawyers for the other side, who were pretty tough customers. But I knew I was in for an easy ride when I heard the lead lawyer for the other side say just before my cross-examination, I can't stay long today. I've got to get to my cabin. So I thought, well, that's Canada. I love it. I love it. Now, there is one outstanding counterexample. That is to say, a study that we cited and we had presented to us by the authors, Nancy Ross and Jim Dunn and John Lynch, and that analyzed whether there was or was not a correlation between working age mortality, 25 to 64 years of age, from all causes, and median share of income, another measure of income inequality, in the metropolitan areas. So that's very important. It's the question of scale, of course, as geographers would know. In 5 countries. And the answer was, as I recall, there was no association in 3 of the 5 countries, only in the US and in the UK, rather telling. And I'd like to know, for those of you who've kept up in this field, and that probably includes you, Ichiro, whether you think that has been resolved, that question. If there's no correlation to start with, it puts the spirit level hypothesis on much shakier ground, obviously. Now, the third theme that we probably spent most of our energy evidencing in that pop health program was this idea that there were individual level socioeconomic and cultural factors in the immediate social environment of the person that influenced our health over the life course. And that there were these long latency effects often attributed in terms of the person who first nailed many of them down epidemiologically to David Barker, working in Southampton in the UK. And of course, these exposures interact with our genetic predispositions, as we've already heard Ichiro speak about. Now, when I teach health inequalities, I'm tremendously influenced by Fraser, who always said, it's a gradient. It's not just that the rich are healthy and the poor are unhealthy. It's a gradient. Everybody in between is somewhere on a ladder. And so I always say there are 3 features of these gradients that are important and actually reveal something about the determination of health. The first is they have a fractal tendency, meaning you get the same kind of monotonic pattern in terms of slope sign when you put the risk of bad health outcome against SES level, no matter how many quantiles of rank ordered SES are used in the analysis. And I'll show you an example in a minute. And secondly, is they cross over wildly different disease and traumatic outcomes. So the word protein is used to describe that. They cross over pathogenetic pathways. And lastly, and this point has been made by Ichiro and others, they're remarkably hard to change. And I'll show you the example of Scotland, where I moved in 2008 in order to better understand all this, because it had, and it still has the steepest health inequalities by social class in all of Western Europe, and some of the steepest in the developed world. And when I introduce this topic to people, I always say, well, this evidence has been around a long time. This is a Scottish mortality follow-up in a cohort, I think was based on the census, which was begun 1980, so a long time ago, And it shows by the Carstairs on the x-axis, the Carstairs index of deprivation. Why I asked people about their deprivation, like questions like, do you have an indoor loo? Do you have access to a car? Do you rent or own? Those kinds of questions. Well, because Scots are particularly difficult to get information out of regarding their income, and still true today. So you had this questionnaire, and all these people were given the questionnaire, and they were followed up for their death rate. This is age standardized. I think it's both sexes combined. And you see this fractal pattern that even though there are 7 categories of rank ordered deprivation, you see this fine gradation. And you see, as in many such data sets, a slightly lower slope, lower on the gradient for people over age 65. And most of us explain this when we're teaching it as the results of selective culling through mortality at the advanced age of those individuals most susceptible to the effects of social class. Whether that's really true, I've never seen it tested in a robust analysis. And this is the slide from the same early Scottish social epidemiological study showing that the gradient was in the same direction for this wide variety of causes of death, some of them no longer hardly ever occurring, like stomach ulcers after the advent of modern medication for that condition. Of course, it's not universal, and we all know health outcomes, those of us in epidemiology that are more have the opposite directionality of relationships, such as breast cancer incidence in women in most advanced societies. But we know the cause. It's due to confounding by the very different reproductive lifetime risk factor profiles of less and more educated women in particular. I could give you other exceptions, but let's just say they are the exceptions. And then finally, just a few slides about how Scotland demonstrates the extreme difficulty, the inertia of social class inequalities in health. So there it is, in obviously occupying the top third of the UK. It's got about 5.34 million people compared to the UK's 68 million or so as a whole. So it bears a similar relationship in population terms to England and Wales as Canada does to the USA, if you like to think of it that way. What happened about 30 some years ago in the 80s is there was a demonstrable rise in mortality inequalities by family markers of social class in teens and young adults due to external causes, that is drugs, alcohol, violence, self-harm. And that these conditions were related. We just had a little dance music there, but maybe didn't come in at the right point. Conditions related to mental health, but strongly influenced by local culture and the social environment. And we know this because the problem was particularly marked in areas such as Greater Glasgow, which had gangs well established. But it took over in females, the same phenomenon. Within a decade later, gangs were not prominent in that development. And the Scottish government has published a mountain of very well-written documents by Oxbridge graduates in the policy shops of the public sector, saying we're going to fix this. We're going to reduce inequalities in Scotland. There's quite a lot of ambition to do that in Scotland today. However, Scotland did not have, until this year and next, really, the key policy levers, tax and transfer, that is social welfare policies within its remit. And they're just about to be devolved. And let's see how Scotland does when it has the power to do interventions. On the positive side, this situation has led to the development of a very good monitoring system. Annual Scottish government reports have expertly monitored time trends with this incredibly low-cost methodology now being experimented with by Canada, which graphs all the health events in the whole country as collected by routine administrative data sets, whether they're deaths from a cause or whether they're hospitalizations or a measure, well, on a survey, it would be self-reported and not the whole population. But they look at that across the top and bottom deciles of the postcodes, which are grouped into 7,000 SES index ranked small areas, data zones. And those are designed so as not to gerrymander natural communities, such as social housing estates, where a lot of poverty is concentrated in the UK. And so ironically, for epidemiologists, it covers the whole population. So there's no sampling error, if you like, but There's stochastic fluctuations for rare events. I think there's one more thing at the top here, which is that these inequalities, I pretty much said this, they not only began as the highest, the steepest ones in Western Europe, but they've hardly declined. And to give you one example of how they're elegantly depicted every year in the Scottish Government reports, all the graphs amongst a dozen or so health outcomes that are analyzed annually show this picture, which is on the left is the outcome. This is age standardized, European age standardized death rate from all causes. I think it's both sexes. It's adults. And you see that there are two lines against calendar time, about nearly 20 years of calendar time. And we have the rate in the most deprived decile of postcodes, which are rank ordered by the Scottish Index of Multiple Deprivation, based on census and updated unemployment statistics in particular. And in the wealthy, leafy suburbs of Newtown in Edinburgh and Bears Den in Glasgow, some of the most sophisticated people anywhere in the world, the top decile of Scots by SES. And you see that the gap was coming down very, very, very slightly until about 2013, 14. And then we have this strong uptick, and that uptick has continued. But it's not identical to the deaths of despair of Case and Deaton in the United States. It doesn't mean they're not related in any way, but there's quite a lot of research evidence now, particularly from England, that this was very strongly concentrated in the elderly and the disabled, and of course, exclusively in the poor, as you can see by the graph, related to austerity policies, social welfare cuts, which were extremely draconian and frankly cruel. So one of the great things about this approach to monitoring health inequalities by social class is that you spot things earlier than you would otherwise if you just were looking at the whole collective total population mortality pattern. I don't think you'd see much. Now, as backdrop to this, and Ichiro hinted at this, how would you expect, how could you possibly expect the gap by social class in mortality in a society to come down if very major biological determinants of health, such as smoking, were becoming progressively more concentrated every decade in low socioeconomic status subpopulations? And that's what we see in this very well-known graph, which is when I was a wean, as they say in Scotland, in the 1950s, women of all social classes smoked about the same amount, prevalence from 40 to 45%. And over the following 50 years, there was this very steady and substantial decline in women in the professional class. We're using the old Registrar General's occupational classifications because that's where the data, what data we have for such a long period. And the women who are in the unskilled manual class, a very small decline indeed. And so that we've got this, 2.5-fold gradient here between across these extremes by 2000. Well, now that gradient is much bigger. It's easy to find Scottish local spatial inequalities between, say, housing estates and leafy suburbs of 5-fold or more. And that is a very tough problem to solve. Final theme, and I need to finish up now because my time's coming to an end, is this idea that the health manifestations of social class are protean. They span diverse disease pathways. And Fraser, I think, was particularly interested in this because he was a pathologist, highly published pathologist, and he immersed himself in the relatively new fields of psychoneuroimmunology and psychoneuroendocrinology to try and understand how life, everyday life, and the stressors of it get embedded, as Clyde used to say, under the skin, combined with the long life latency perspective of David Barker. So this is Fraser's slide. I and Clyde wrote a chapter in the second book by the group to kind of update people on this material because there weren't too many physicians in the group interested in biology. But I have to say, I would never bother doing that again because I put at the bottom of the slide, is there anyone anywhere who still doubts that daily experiences shape our health throughout life by a strong body-brain connections? And one of the great demonstrations of this idea published by Chris Power, and maybe Clyde was a co-author on this, out of the data in the 1958 British birth cohort, was when you looked at the dose-response relationship between socioeconomic status over a life course through to age 33 and the outcome, self-rated health, there was a very strong dose-response relationship. So the score is based on how deep deprivation was for these people based upon repeated questionnaires over their life course with several data collection waves in the cohort study. And you see, of course, there's a massive difference between people who had very, very small doses, life course doses of low SES had only less than 5% of them had self-rated health status at the level of poor, compared to almost a quarter of those with the highest dose level. And that was something Clyde was particularly keen on, because he and Michèle Wiens, maybe you're on this call, Michèle, wrote a very, very well-cited paper in Social Science and Medicine about different dosage response patterns between SES and health. And I think this is just sum up my last slide. Around the mid-1990s, I think it was, the group discovered Doug Wilms. Doug, I hope you're on this call, University of New Brunswick at that time, but had done his doctoral work here in Edinburgh. And he, I think, more or less discovered this fabulous fan pattern internationally, depicting the relationship between standardized educational attainment scores by testing. On the y-axis, it happens to be literacy tests. And on the y-axis, I'm sorry, that's on the y-axis, and on the x-axis, the parent's average level of education of the child who's being tested. This happens to be youth, so they pretty much finished most of their schooling. It would affect their literacy. And what you see is the pattern is fanned so that where you're born only matters if your parents are low SES. Because if your parents are high education level, everybody does well in all these countries. But if your parents are from a very low education level, barely finished primary school, you have a pretty good shot at a high attainment in Sweden and the Netherlands, a bit less in Canada, and a very poor chance in several of these countries in the lower left-hand corner, which are have a more than, I would say, expected representation of English-speaking countries, including Great Britain and Scotland, which is a very similar gradient here, which has not come down the way people have hoped, as monitored in the regular testing by PISA, the Program of International Student Assessment of OECD. So what's the factor there that pushes up these Northwestern European countries' performance in their educational attainment for deprived children, children of more deprived backgrounds? The key policy is probably, one of them at least, is universal, free, accessible, high quality preschool. And the evidence for that is just accumulated early in the last decade. And I've become convinced of it. I frequently speak on it and tried to work on it in Scotland, but it's still not been implemented. And there are many excuses: teacher availability, cost, and I hope that it will be implemented. And in Canada, you may have even a steeper hill to climb in that regard, given the history of the demolition of a federal, provincial, territorial childcare agreement at the beginning of the Stephen Harper regime by his government. So last slide, Fraser's slide. I think it was related to the predecessor of Heckman, Jim Heckman, who's done many analyses to suggest this, which is that the greatest returns on investment, we're talking literally here about public sector investment, are in early life, when the brain is malleable and the wiring of the brain is being set down by experience. And yet we're forced by compassion and the nature of the care system to spend more and more and more as people get older. And there's this mismatch. And I just would ask you in closing, do most of us still believe that we have a problem of underinvesting in our children and wasting resources in old age? That's a harsh way to put it. I'll just finish with this reflection. What would I want the CIHR Public Health Program to do differently if we had a chance to do it again? Not much. It changed my life for the better, and many other people's, both career-wise but intellectually, and I'm deeply indebted to it. And this talk is dedicated to my many colleagues from that program, including a few who've left us prematurely. Fraser and Clyde, rest in peace and thank you.
Thank you so much. That was wonderful, and it's really nice to see Clyde Fraser acknowledged in that way. You'll see another poll, audience members, that asks, "Do you think we have a good understanding of how to resolve socioeconomic health inequalities?" I am just going to give a quick 2-minute break, literally 2 minutes, because we're running quite behind. And then we will come back to hear Dr. Lamont's presentation. So just 2 minutes, so 11:26, we'll come back. Thanks, everyone. Well, it's now my distinct pleasure to introduce to you Dr. Michèle Lamont, who is professor of sociology and of African and African American studies at Harvard University, and also, the Robert L. Goldman Professor of European Studies there. Michèle was also, with Peter Hall, a co-director of a very influential program for population health and hopefully for social science as well, called the Program on Successful Societies that Vivek alluded to earlier, that was part of the Canadian Institute for Advanced Research. Michèle, it's really a pleasure to have you here. We really appreciate you, and I'll turn the mic over to you.
It's a real pleasure to be here. I hope everyone hears me. So I want to talk to you a little bit about the history of the Successful Society program, which built directly on the work of the population health program that was mentioned by John and Ichiro. In 2002, I was asked to co-direct this program with Peter Hall, and with the mission to bring in more insight from the social sciences, but particularly from sociology and political science, into the study of population health. So the team that was assembled by CFAR was brought together with people like Clyde Hertzman, and Dan Keating, who had been involved in the program on human development, to try to bring new analytical tools to understand questions related to human development and population health. So what we did is we defined a research agenda that built on our knowledge of inequality. Several of us were scholars of inequality, and we wanted really to try to raise new questions about determinants of population health that had not been asked previously. So the standard approach to inequality is very much our program started in 2002. So much has happened over the last 20 years in the study of inequality, but at the time it was very clear that much of the research on inequality was still focused on problems and was very policy oriented, and was focused on questions of distribution, patterns of unequal distribution of a wide range of resources. So the focus was generally outcome instead of processes. And we were particularly interested in studying cultural processes, cultural dynamics, and the role of institution in influencing how inequality was shaped. So this opened us to a wide range of questions that had not really been at the center of population health. Questions of recognition, inclusion, cohesion, and solidarity, which I believe have become much more central to the study of inequality over the last 20 years. And the program over these years produced 3 outcomes that I'm going to talk about briefly. A first book in 2009 titled Successful Societies, How Institution and Culture Affect Health. And it included a number of chapters, one of them co-authored by Arjumand, on population health and collective development. So the question there was very much, it was a chapter centered on Vancouver and trying to make sense of why some neighborhoods were much better at mobilizing around the improvement of population health than others. So it focused on questions of institutional capabilities and what were the factors that facilitated that. It was very much connected to a chapter by Anne Swidler, another group member and a sociologist who studied the role of African chiefs in mobilizing in Uganda, versus Kenya, mobilizing the population against AIDS. So the question of which cultural frameworks could be mobilized to appeal to collective good was at the center of inquiry. So this, we really aim to create a unique dialogue, bringing people, social scientists, who are attuned to the empirical study of the frameworks through which people understand reality with the study of patterns of distribution. So some of the themes that were central to our inquiry was really this focus on cultural, social, and economic processes in the reproduction and production of inequality. And we aim to connect distribution and recognition. And by recognition, we mean the process by which groups that have been stigmatized historically are being redefined as worthy, as legit in society at large. And you recognize here some of the themes that have become extremely predominant over the last few years with, for instance, the book by Case and Angus Deaton, Death by Despair, which I'll return to in a second. And unlike much of the literature concerned with inequality, we were very concerned with connecting the micro level, the meso level, and the macro level. So one example is a study of the decline in attempted suicide among LGBTQ youth in high school after the adoption of same-sex marriage laws in 32 American states. So this is a case where the adoption of those laws sent, to citizens new messages about who belongs, who's legit, what kind of behavior is acceptable, which was translated directly into a decline in these suicides. So this is an example of the kind of phenomenon that we were interested in. And more broadly, some of us in the group became interested in understanding the processes through which groups become, destigmatized, and the role of institutions, in this case, the law, in transmitting cultural messages about group boundaries and the transformation of group boundaries. So as you can see now, we're quite far from the kind of research that Ichiro and John described, and yet it's very much informed by the agenda of population health, especially as it was defined in Canada, and which had such an influence on the work of Wilkinson and others. Yet, unlike Wilkinson, we were not concerned with documenting broad demographic patterns or patterns at the macro level, but really in understanding the micro processes that could help and meso, focusing on culture, institution, and network, in understanding the pathways through which these changes could happen. So in the summer of 2009, we produced the third book that came out from the Successful Society program, was a special issue of Day Dallas, which focused specifically, which brought together a lot of psychologists with cultural sociologists, expert of inequality, and political scientists to look in even more detail at these micro, meso, and micro patterns. So I invite you to look at this issue if you're interested in learning more about what we did. But I want to spend a little more time on our second book, which came out in 2013, titled Social Resilience in the Neoliberal Era. And what this book focused on was really the impact of market fundamentalism, which is the economic dimension of neoliberalism. The first chapter of this volume argues that neoliberalism manifests itself at four levels: economic, political, administrative, and cultural. And the cultural level really has to do with widely institutionalized scripts of self, shared concept of what an ideal self looks like. That has gained much greater currency as neoliberalism spread cross-nationally. So this is a LexisNexis graph that shows the increase in the diffusion of the term neoliberalism in Europe and the US, and you see how fast it has increased after 2010 on both continents. And what in my personal work, I've been partly interested in the diffusion of these neoliberal scripts of self that in many ways are represented by the values that Trump's promoted and still promotes, having to do with the values associated often with capitalist, and market fundamentalism, a focus on self-reliance against this, support by the state, competitiveness, material success, and social status. And meritocracy is associated with this to the extent that success is viewed as the result of individual effort and the ability to compete, which is celebrated in these neoliberal scripts of self. So these orientation, this meritocratic orientation, we have data on its growing influence over the last several decades. And we know that it has gained enormously in popularity across most countries, but in all but 5 of the 23 advanced industrial societies that are taken into consideration in this paper in Socios published by Jonathan Michèle, and it declines only in Canada, Australia, and France. So this really indicates a massive increase in the popularity of meritocracy, but with this comes many downsides, mostly at the level of mental health. So we know that in the US, there's been, huge increase in the extent to which the upper middle class is pushing its children to achieve, to compete. And so we have a lot of data showing a decline in a real crisis in mental health for both upper middle class adults, professionals, that's college educated professionals and managers, but it's also central in the middle class, which feels very unsteady and concerned about downward mobility. The studies by Case and Deaton have given us plenty of evidence on the impact on the working class, the opioid epidemic, and in the case of the poor, we have growing stigmatization and even more of a disaster scenario. Those of us who teach all of us on the call who are professors are also aware of how our students are facing a major mental health crisis with huge amount of anxiety. And this has been very much connected to the increase of inequality that goes hand in hand with the diffusion of these neoliberal scripts of self. The children are simply asked to compete and to not pay as much attention to their emotional and personal needs with the disaster that we're facing today. This is a very well-known study, the UCLA freshman study that has been tracing this crisis in mental health among young Americans, college students. You can see here the number of them who are feeling overwhelmed has just increased considerably. So what can we do? I mean, now I'm going to conclude with trying to tell you the ways in which this research of the Successful Society program has really pushed me in a direction that I would not have anticipated, which is really about if we're facing this crisis connected with the overwhelming influence of neoliberal scripts of self, where do we find hope? Where do we find new ways of telling people that there's many ways of being okay? So in order to study this, I have put together a project where I'm analyzing the emergence of new scripts of self in the media. And this is done taking into consideration that the public sphere, the character of the public sphere has changed enormously in the last decades with the growing prominence of social media, and there are many changes in how the public sphere is transformed. So I've done over 160 interviews with people in different sectors of cultural production. One of the most fun parts of the project has been interviewing over 75 people who are creatives in Hollywood and stand-up comics. So, for instance, the person who is behind The Handmaid's Tale, which offer us, critical ways of thinking about what kind of society we want. And there's also a number of artists who are giving us new depiction of who's legit. So I've interviewed a number of people, artists, for instance, who are depicting LGBTQ people in a positive light. This is a work by Lyle Ashton Harris. There's also a woman named Catherine Opie who did a lot of photographs of the letter community in LA that she belongs to. And she says, we're used to being described or portrayed as, child murderers. But in fact, we are loving people who have dignity. And I want to represent those people the way that they imagine themselves. So she, along with a lot of other people I've interviewed, are really involved in a major enterprise to transform the representation of stigmatized group to broaden cultural membership, which, as we know, we're going to hear from David Williams in this symposium organized by Arjumand, has a direct impact on racism, has a direct impact on health and the transformation of the framework through which groups of people are perceived matters a lot to the question that we are pursuing in the symposium. So I'll conclude with a brief mention of this paper that I co-authored came out in Social Science and Medicine, which is about the process of destigmatization. Groups that are stigmatized, how do they come to not be stigmatized? So we compared people living with HIV/AIDS, African American, and people labeled as obese, drawing on the secondary literature on the destigmatization of these groups. And we came up with a model. We compared the conditions that lead to the successful destigmatization of people with AIDS as opposed to people labeled as obese. And we found that in the successful groups, the role of knowledge experts was absolutely central, work in coordination with social movement activists, which were conditions that were not present for obesity. So we have a general model that points to how specific actors, such as the cultural producers I'm now studying, are drawing on surrounding cultural resources to engage in destigmatizing action and finally destigmatizing outcome. So what we have at the end are people like Lizzo, who celebrates body acceptance, which is a value that is extremely central to Gen Zs and millennials, that are really showing that perhaps the destigmatization of obesity is around the corner. And we can certainly, when you think about the aftermath of the Black Lives Matter movement of this summer, there's a large number of organizations where you have a process of elite replacement with people being named, for instance, at the head of many of the leading foundations in the US who have chosen to put social justice at the center of their agenda for the next few years. So this is a case that really, it's a little bit of information that helps us understand that this is a process that's happening at the macro level, and we really need to understand it better, since it will certainly have an impact as we're moving away from a unidimensional understanding of what success look like, which would have an impact on health outcomes, hopefully on the long term. And it also suggests the ways in which the field of publication health population health can really feed new kinds of cross fertilization with other fields, such as my field, which is cultural sociology. So these are the wonderful RAs who are involved in the project. So I thank you for your attention. Unfortunately, I'm giving a talk in Ohio at 12:30, so I may have to leave before this session is over. But if you have any comments or questions, please don't hesitate to reach out to me. Thank you.
Thank you so much, Michèle. And Ichiro and John, I'll invite you to turn your cameras on and unmute yourselves as well. Here's another poll for the audience in response to Michèle's talk. Do you think that socioeconomic inequalities should be addressed mainly by any of the following groups? I just want to say that I have received so many comments saying that this has really been an incredible session with so many people's public health and social science heroes on it, and so it's been just lovely to hear all of you, and it's exactly the kind of intersection that I wanted to see. Michèle, you brought up so many things that I think you're right. We don't quite sort of tackle head on in population health, and will be interesting to talk about. I'll invite the audience to start sending your questions through the question and answer part of Zoom, and we'll try to get to at least one or two of them. I'm going to sort of condense the panel discussion and the audience Q&A and sort of merge them into one, if that's okay with everyone. But let me start out with one observation I had from all three of your discussions. And that was that there certainly is this sort of intersection of what is happening at the biological level with what is happening at the meso and the sort of societal level. And not only that there's this intersection, but there's different forces at play. As Michèle pointed out, we traditionally look at policies as a way to understand distribution and inequality. And we look at sort of distributive policies. And certainly in population health, I would argue that, when we look at policies, we certainly have focused on ones that either bring the bottom up or are somehow redistributive as in income inequality as an indicator of. What I'm wondering is whether there is something that sticks out to each of you from hearing these three talks that is an area of society, either institutions, cultural scripts, policies that you think is something that we should really take hold of, that we haven't fully engaged with. So, for example, I saw a few really interesting connections. Michèle, you mentioned ideas, a sense of belonging and destigmatization that come from neoliberal scripts. Ichiro, you mentioned this concept of scarcity and how people feel in sort of in the context of not having very much, and that can be influenced by scripts and by policies. And as you said, any of us could land in that position. John, same thing. You sort of mentioned the austerity policies and so on that have created so much economic insecurity. Where do you see the nexus of those ideas leading in terms of areas of society that we should be probing as we go forward in population health work and in understanding inequality at the population scale? John, maybe I will start with you.
Well, I won't take the austerity example because at least here in Britain, we have so many reasons to think that the government is inept and despicable that austerity is just one of the list. I would rather pick the example of adverse childhood experiences where significant damage is being done by the misinterpretation and misuse of science. So you'll all be familiar, well, if you're not, a guy who's kind of an ordinary internist, not much science training, Vince Felitti at Kaiser Permanente, began to study. He was an obesity doctor, actually. He noticed that a lot of his patients had very bad childhoods. And he thought, well, let's go and ask a whole bunch of people in Kaiser Permanente enrolled, about their childhoods. And he used a pretty good questionnaire. This is all by memory, of course. And then he had independent information about their health problem list because they gave consent for their Kaiser records. And sure enough, there's this very strong dose-response relationship between adult health and bad childhood experiences, adverse health, and in particular for conditions that are mental health or addictions and so forth. So it's kind of deeply embedded in modern science that that's the case. That's not what is bothering me. What's bothering me is that we've had a social movement develop in Britain, which thinks it's a good idea to go and test people individually and put them through a questionnaire about their adverse childhood experiences, and then offer them no counseling, no way out of it, because most of these adverse childhood experiences, once you've had the experience, it's not like it's reversible. The experience is reversible. The effects might be with the right approach. So I actually met somebody who was an early childhood educator, modestly educated young woman, clearly committed to her field. And her whole staff and her whole early childhood education center had been given this questionnaire about their early childhoods. And afterwards, they were half of them in tears, and they were, and I said, well, what did they do with that? Did they help you out? No, they just thought it would be good for us to have the insight. So that's bad science, bad application of science. And I think we have to watch out for that kind of stuff.
Yeah, fair enough. Michèle, maybe we'll go to you next. And we also had another question that I'll see if you might be able to append with this, which is what you think of the myth of meritocracy in neoliberalism, and how does it work to reinforce the stigma of living in a larger body?
Well, I mean, much has been said about meritocracy in terms of it leading people to think that they are fully responsible for their success and that what happens to them is fair. So deservingness legitimizes a unidimensional conception of the social structure, and of a social hierarchy. So what I've been arguing is the need to think about how to develop a multidimensional understanding of what the worth of people are, so that even those who are not successful in terms of upper middle class professional success are viewed as and the two, this very much, the valuation of meritocracy works hand in hand with the American dream. Part of the project has been to do 80 interviews with Gen Zs who are just extremely critical of the American dream because they think they won't be able to buy a house. And this is clearly not for them. So they're turning toward other myths or other values to define the society they want to live in. And that society puts at its center inclusion, including, now non-binary sexual identification, sustainability, authenticity. So I think what we need to do as social scientists is be much more attuned to the ways in which the power of the American dream is vanishing, although it's still sacred to many immigrants, as inequality has been growing. And I'm not sure that the academic community is really on board with this. Because those myths are so overwhelmingly powerful, at least in the American context.
That's very interesting. I mean, especially in terms of where our focus tends to lie in terms of sort of figuring out who has access to the American dream rather than looking at alternative scripts. Very interesting. Ichiro, I might ask you to come back to this question of where you see sort of some promise in terms of the kinds of societal forces that we should be paying attention to. But also we have a sort of appended question for you as well. And that comes back to the comment you made about counterfactual frameworks being inherently conservative. And there may be some overlap there, in fact, in terms of thinking of what matters and how, and the ways in which we study it.
Yeah, thanks, Arjumand. I mean, as many of you know, in social epidemiology, there's been a great interest in trying to fix causality through the counterfactual framework and importing methods to try to sharpen our questions. But what that buys us is, greater security in claiming causality. But the trade-off is that the more we do that, the narrower the questions become, and the more distance we become from the sort of real background forces, such as neoliberalism, which is sweeping many democracies around the world. And so I think it's always this tension between our tendency to focus on narrower questions, but ignoring the bigger questions that really hold promise of changing society and mitigating health inequality. I don't think that any of this is either or. I mean, I spoke about looking inward and outward. We need to look inward in order to better understand what's going on and create our own script, perhaps to convince policymakers that this is a real phenomenon. And at the same time, we have to keep our eyes focused on the broader forces that shape people's lives and create these inequalities. I think, often the frustration of a social epidemiologist is that many of the solutions we suggest are actually beyond our individual control, aren't they? I mean, this was a big change that happened to me from when I used to practice as a physician, where I could identify a problem and prescribe a treatment on an individual basis. But everything I study these days is about changing the distribution of income or changing policy in housing or something. And it seems to me that we have to simultaneously keep focused on the broader forces as well as to focus inward on providing more convincing evidence of why these linkages exist.
Yeah, very interesting. And in fact, as I think about it, in some ways, one thing that links the three of your presentations is this inward outward tandem. So, in some ways, Michèle's ideas about the scripts that are being taken up and that are offered by societies and what impact they have on people's well being is, in some ways, an inward process that we really haven't explored much in population health. And simultaneously, it speaks to the outward. It speaks to what kinds of institutions and environments foster certain kinds of scripts and not others, as Michèle's work really nicely talks about. And I think I see the same in John's examples of Scottish environments. So there are these really interesting observations about socioeconomic gradients in Scotland and elsewhere. John, you talked about how consistent they've been across outcomes and across time and so on, and across sort of various indicators of socioeconomics and different quantiles of socioeconomics. And there's something deeply intimate and personal and mechanistic about understanding that. And yet, the sort of broad perspective on it is that there must be something larger, something outward that we should look to explain how and why that happens. And so maybe sort of as a last offering, as we launch into the rest of the weeks of this symposium, there is this call to maybe not see looking inward and looking downstream and looking upstream as trade-offs, but rather use both of those learnings to sort of to create a better picture and a broader picture of what drives health and health inequalities. I'd like to thank our three speakers very much, more than I can describe. It's such an honor and such a pleasure to be with you guys. I thank you for joining us for our first session and launching us on our way. Thank you to the audience for attending and for your comments and questions. And we look forward to seeing you next Friday at 10 a.m. Toronto time. Thanks again to everybody. Bye-bye. Have a great weekend.
Thank you.
Bye.
Bye, everyone.